Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor of MIMS Learning, and today I have with me my colleague, fellow medical editor, Dawn Liz Powell.
Hi.
Today I want to talk about something that accounts for nearly 1/3 of GP consultations, musculoskeletal disorders. This is a vast area. It can cover anything ranging from acute injuries to chronic conditions, and of course, is challenging to diagnose given the breadth of symptoms and differential diagnoses.
Yeah, and just to put that into perspective, so 1/3 translates to about 20 million people in the UK, so that's 20 million people who have some sort of musculoskeletal issue. Given we are all living longer, people with musculoskeletal conditions are living longer with their conditions. Not only will have this effect on their lives, but this will have an effect on the NHS in terms of cost.
And given how broad this topic is, I've tried to break it down into a few key areas so we can navigate it better. So let's first talk about when some musculoskeletal symptoms can be red flags. Then we look at an underdiagnosed inflammatory condition. And finally, let's discuss the very common back pain. How does that sound?
Yeah, it sounds like a good plan. Should we dive in?
Yeah, sure. Let's kick off with some red flags. Muscle weakness is the first one that I want to talk about. Dawn, what are some of the key red flags in a patient who presents with muscle weakness?
Okay, so on our red flags module on muscle weakness by Dr. Pipin Singh, the red flags are persistent weakness lasting for more than 4 weeks, muscle wasting, and unusual paraesthesia.
Dr. Singh says having a focused examination will help reveal the etiology. First and foremost, it's important to understand why the patient presented and what they understand as muscle weakness.
Yes, so important things to determine are whether the muscle weakness came on suddenly or gradually, the location of the weakness, and if there are any associated signs and symptoms. So what does Dr. Singh say are the possible causes of muscle weakness?
So there can be a range of causes, including neurological, rheumatological, gastrointestinal, and endocrine. Malignancy can also be a possible cause. Among neurological causes, Guillain-Barré syndrome secondary to acute illness would warrant same-day admission. Cerebrovascular accident or transient ischemic attack, neuropraxia, muscular dystrophy, myasthenia gravis, motor neuron disease and multiple sclerosis, and primary neuropathies are other possible causes.
He also says rheumatological causes include polymyalgia rheumatica, fibromyalgia. Additionally, conditions that can cause malabsorption and consequently musculoskeletal complaints should also be considered as a possible cause. Another thing to consider is diabetic amyotrophy.
Muscle weakness can be debilitating. Dr. Singh says, refer to neurology those patients who have true, objective muscle weakness and in whom no other obvious causes can be found. We've all felt that sensation of pins and needles when we've sat in an awkward position for too long. Well, when you can't shake that feeling, it's probably time to see a GP.
Yeah, so in most scenarios, pins or needles or paraesthesia, to give it its technical name, is common and often temporary. However, when it's without an obvious cause or is persistent, it can indicate there's an underlying condition. Red flags for paraesthesia, according to another module we have by Dr. Pipin Singh, include behavioural or memory changes. And then history things to be aware of include heavy alcohol use, recent trauma, surgery or systemic infection. The involvement of multiple areas and or the presence of fever or other systemic upsets are also red flags.
So short-term paraesthesia and indeed some chronic cases usually occur because there's a mechanical pressure to the nerve that's compressing it. In addition, if it's a chronic case, it could be because of endocrine disorders or deficiencies such as hyper or hypoglycemia or B12 deficiency, which we have talked about in a previous episode. Infections such as Guillain-Barré and Lyme disease, medications and toxins such as alcohol misuse, and benzodiazepines.
There can also be vascular causes such as acute limb ischemia, neurological conditions like migraine and sensory epilepsy, and musculoskeletal disorders such as progressing arthritis. For more information about the possible causes, do take a look at the module I've just mentioned, as Dr. Singh does provide a detailed list of possible causes. Okay, so what about the investigations?
So, investigation would involve baseline bloods to check for signs of inflammation, calcium levels, ESR, deficiencies in vitamin B12, thiamine, or ferritin, or metabolic dysfunction. Nerve conduction studies may also prove to be useful. Another common complaint is bone pain, particularly in older people. Often people will describe it pretty vaguely as pain in their bones. So, how would a clinician approach a consultation such as this?
Similar to what we were saying before, and this is in another red flags module we have on bone pain, the clinician should establish what the patient means by the symptom they are describing and why they've come to their GP about it. Bone pain is generally described as a dull, deep-seated pain, which would sort of tie in with the pain in the bone thing you were just saying there, Sangeeta. If widespread, it may be indicative of a physical manifestation of a psychological cause. But I think we should just clarify that if we are going to talk about pain being related to a psychological cause, we should, of course, be very aware that people who've got some sort of pain condition are very, very sensitive to that. And there's been a lot of medical gaslighting about pain being psychological. So it's just something to be incredibly aware of if you're going to go down that route.
Absolutely, that's one topic you have to approach very carefully. Smoking history and family history of osteoporosis may also be important.
And just to sort of say, the red flags with bone pain include fever, malignancy, recent steroid use, a history of tuberculosis, a pain that changes or persists at night, including thoracic pain that wakes the patient up, new onset urinary tract symptoms in men, night sweats, and symmetrical joint swelling are also red flags in somebody presenting with bone pain.
And while history will determine the investigations to proceed with, blood testing for calcium, FBC, ESR, LFTs, phosphate, and vitamin D may also be considered. Chest X-ray, MRI, and plain X-rays may be used if history and examination warrant imaging. Tests for anticyclic citrullonated peptide antibodies and rheumatoid factor proteins to check for rheumatoid arthritis if suspected. Using the fracture risk assessment tool, FRAX, to evaluate bone fracture risk may also be necessary. Those are some of the red flags. Next, we have inflammatory conditions. What historical inflammatory condition comes to mind that's still very much present today, Dawn?
I'm going to say gout.
Good choice. So it is, after all, one of the most common inflammatory arthritis in the world. History of disease fascinates me, and gout has an interesting one. Did you know that once it was called rich man's disease?
Yeah, it was because gout historically was only seen in people who could afford very rich foods, so like lots of meats, seafood and alcohol. I think Georgian caricaturists were always drawing rich gentlemen, possibly King George IV, with gout as a means of satirising them. But what causes gout?
So it's caused by these monosodium urate crystals or uric acid crystals, which are basically forming inside and around your joints, and it presents as sudden flares of severe pain, heat, and swelling. And though any joint can be affected, it typically involves distal joints like the toes, knees, ankles, and finger joints.
Yeah, and so in the UK, gout is diagnosed through a serum uric acid assessment and managed as per the NICE guidelines.
And in its treat to target strategy, NICE discusses the following steps for management. Start on low dose uric acid lowering therapy or ULT, checking uric acid levels monthly, increase ULT doses guided by the uric acid levels until the target is achieved. Aim for a uric acid level of 360 micromoles per liter or 300 micromoles per liter if patients have frequent attacks. Chronic gouty arthritis or tophi, which are urate crystals that deposit and form nodules within the body, and ensure that uric acid is measured at least once a year on stable treatment. Certain lifestyle choices can actually help prevent future attacks. These include maintaining a healthy weight, exercising regularly, drinking plenty of fluids, and reducing alcohol intake, including plenty of fruits and vegetables in the diet, and avoiding foods that are high in purines, such as red meats and seafood.
Okay, so just in terms of what NICE says, NICE recommends that healthcare professionals consider a follow-up appointment after a gout flare has settled to measure the serum urate level, provide information about gout and how to self-manage, and reduce the risk of future flares. Healthcare professionals should also assess lifestyle and comorbidities and review medications and discuss the risk and benefits of long-term ULT.
Moving on from gout, let's discuss axial spondyloarthritis or AXSPA. Despite affecting 1 in 200 adults in the UK, 91% of the UK's population has never heard of it. In our on demand webinar, specialist physiotherapist Jenny Elkin says that AXSPA is quite a new term, which was previously known as ankylosing spondylitis. Currently, AXSPA is defined as an inflammatory arthritis where the main symptom is back pain, and it's a broader term that includes ankylosing spondylitis. Dawn, what should raise a GP suspicion for AXSPA?
The key features include a slow or gradual onset of back pain and stiffness, early morning stiffness and pain that reduces with exercise or feels better with exercise, and pain that persists for more than 3 months. AXPA should also be considered in people with inflammatory pain or functional impairment.
AXSPA also has a range of extra-musculoskeletal manifestations, and the most common ones are acute anterior uveitis, IBD, and psoriasis. So, for patients who present with chronic back pain plus an extramusculoskeletal manifestation, Jenny suggests seeking advice and guidance or referring to rheumatology.
This is one of those conditions which is notoriously difficult to diagnose and can have a lasting impact if the diagnosis is delayed. It really is an important one to catch early.
Yeah, and what's the diagnostic pathway from primary care?
Okay, so if a GP does suspect AXPA, the next step would be to consider blood tests, including HLA-B27 testing, though a negative test doesn't rule it out. Imaging, specifically X-ray and MRI, can be used, although MRI is more sensitive for detecting early inflammatory changes. Treatment is with NSAIDs and biologics, if the NICE criteria met, as well as DMARDs. Do have a watch of the MIMS Learning webinar because it does go into a lot more detail.
This takes us on to back pain, a ubiquitous complaint in primary care. Let's start with acute low back pain. What's a general approach for uncomplicated acute low back pain, Dawn?
Acute low back pain is incredibly common, and for most people it's self-limiting. But say they've gone to the GP about it, a clinician should take their history and assess the duration, location, severity of the pain. And also where there's a loss of sensation, which may signify radiculopathy, the extent of functional impairment to the patient, and any precipitating factors.
And it is worth looking out for red flags in acute back pain. Cauda equina syndrome, it occurs when there is a sudden large disc prolapse and compression. It can produce long-lasting effects with loss of bowel and bladder function if not treated. It is considered an emergency. Symptoms can include severe or progressive bilateral neurological deficit of the legs, recent onset urinary retention or incontinence, recent onset fecal incontinence, saddle anesthesia, or unexpected laxity of the anal sphincter.
Another concern in a person presenting with back pain is spinal fracture. Spinal fracture, presumably in someone with an underlying condition that makes them susceptible to fracture, can be triggered in a seemingly innocuous incident such as picking up a shopping bag. Cancer and infections are also possible causes of back pain.
NICE recommends offering self-management advice tailored to the individual, analgesia, advice on follow-up if symptoms persist or worsen after 3 to 4 weeks, and advice to report any red flag symptoms or signs.
The NICE guidance on back pain also states that oral NSAIDs can be considered for low back pain. This should be at the lowest effective dose for the shortest possible period of time. Weak opioids with or without paracetamol can be considered if NSAIDs are contraindicated. However, paracetamol alone should not be offered, nor should SSRIs, SNRIs, tricyclic antidepressants, and gabapentinoids.
So, what have we learned today? First, it's important to understand what the patient means when they say they have muscle weakness and bone pain. Investigations for both include blood work and imaging. Red flags for muscle weakness include persistent weakness lasting for more than 4 weeks, muscle wasting, and unusual paraesthesia. While red flags for bone pain include fever, malignancy, recent steroid use, a history of tuberculosis, a pain that changes or persists, pain at night, including thoracic pain that wakes the patient up. Red flags for paraesthesia include behavioral or memory changes and a history of heavy alcohol use, recent trauma, surgery, or systemic infection. Second, gout management usually includes starting the patient on a low-dose uric acid lowering therapy or ULT, checking uric acid levels monthly, increasing the ULT doses guided by the uric acid levels until the target is achieved, and aiming for a uric acid level of 360 micromoles per liter or 300 micromoles per liter if the patients have frequent attacks, chronic gouty arthritis, or tophi. Ensure that uric acid is measured at least once a year after the patient is on stable treatment. And finally, axial spondyloarthritis or axSpA is a notoriously underdiagnosed condition, and key features include a slow or gradual onset of back pain and stiffness, pain that reduces with exercise and worsens with rest. axSpA is also associated with extra-musculoskeletal manifestations, the most common ones being acute anterior uveitis, IBD, and psoriasis. Thanks for joining me for this discussion today, Dawn, and thank you for listening. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Join us next week, where our colleague Rhiannon Ashman will be sharing highlights and speaker interviews from MIMS Learning Live. See you next time.